Yeah, thanks for giving me the opportunity to present today on TB Echo. I feel like this is kind of one of those like long time listener, first time caller situations. So I'm really happy to be on board here. So I think I know a lot of you, but for those of you who don't know me, I'm David Miller. I'm with the DOH TB program here in Washington. I used to work locally for many years as a TB case manager and lead for Yakima County in Washington. And now for the last 2.5 years or so, I've been with the Washington Department of Health. All right, so I don't have any conflicts of interest to disclose. Objectives today, really my main objective is to just kind of stir up a little conversation about sputum induction and the TB care kind of continuum and see if maybe we can use it a little bit more than we do now. But to be specific, we're going to talk about the efficacy of sputum induction, safety, some indications for its use, contraindications, just some ways that you can find some best practices and resources to help you with sputum induction with your patients. Okay, so why do we even collect sputum samples during TB care? I know this is very basic, but sometimes I feel like it's good to bring the basics back into focus. Obviously, diagnosis is the most obvious, for medical providers who want to diagnose tuberculosis, so we collect sputum as part of that. Treatment effectiveness is another clinical reason. This should be obvious to most medical providers, but it's not always the case. We will collect sputum during the months of TB treatment because really it can help us understand how effective our treatment is. It can help tip us off early on if we have a problem, and that could be drug resistance, non-adherence, poor drug absorption. So all of those things that we want to kind of keep an eye on while we're going through treatment. How public health really uses sputum results for lots of reasons, but how infectious a person with pulmonary TB is one of the main things. Should we even do a contact investigation? It's largely driven by the results of sputum testing. And then, when can we take somebody off of isolation, which obviously has huge social and mental health impacts on our patients. And then lastly, one that maybe we don't think about as much, but genetic sequencing is pretty important because it helps us kind of identify any connections that we might have missed in our contact investigation, even clusters or outbreaks that we might not be aware of locally or even, throughout the state or even nationally sometimes. So just kind of looking at all of that and knowing that these results are going to impact so many decisions, the importance of getting quality samples should be pretty obvious, right? So let's talk a little bit about sputum quality. So here's some data that I recently was able to get from our Washington State Public Health Lab. And it shows some interesting patterns regarding the quality of sputum they regularly receive to give us the results so that we can make all these decisions that I just covered. And what you're looking at here is basically the last 5 years or so of sputum that was submitted to the Public Health Lab in Washington. And these first two rows are really the method of how the sample was collected, so either expectorated or induced. And then the bottom three lines, those are really indicating the quality of the samples that were collected. So for each year, we've got a total number, and then we've got the percentages. And if you just kind of look over at 2022, you're going to see that roughly out of the 1,800 samples submitted, about 31% were watery, 19% were low volume, and about 8% were both of those things. And so when you kind of look at it overall, we're looking at over 40% of the samples that were sent to the Public Health Lab were likely poor quality. And if we just look over at 2023, at least up until the middle of December when I pulled this data, it was actually a bit worse last year. We were approaching more like 45% that were likely poor quality. So the reason I wanted to include the method of collection here too is just to show that almost all of the samples that are sent to the Public Health Lab are expectorated sputum. So we really don't do sputum induction very much in in our state anyway, despite how challenging it seems to be to get quality samples from our patients. And I'm right there with you. You know, like I did this for a lot of years. I know how hard it is to get good samples from people, especially once we get them on treatment. So this is not like me trying to, you know, flack our efforts at all. I totally get how difficult it is to get those good samples. So how do we improve it? I mean, that's really what it comes down to. How do we improve the quality of our sputum collection? Still, you know, we definitely want to start by spontaneously generated sputum. We want that to be our first step. It's simple, although not always easy. It's cheap. It's generally safe. But good patient education and coaching are really imperative to getting good quality sputum samples collected for most patients, no matter how you collect it, whether it's induced or, you know, spontaneous expectorated sputum. So I did include some resources here on this slide that you can review later, but they really go into depth as far as patient education and really coaching, which I think is probably the most important part. And I think some of these will be helpful for you to review, whether you're new or experienced. I know when I was looking through all of this, I picked up tips and things that I hadn't thought about in a long time. So, you know, definitely take a look at some of those. I think you'll find some nice little nuggets in there. But as we know, you know, sometimes getting a good sample is very difficult, even with the best coaching, especially after treatment has started, like I said. So really, this did get our team to kind of thinking more about sputum induction. You know, are the results any better? You know, we talked to some around the state that were already doing sputum induction. You know, some of our out-of-state partners that were doing this, and then we researched, you know, or we reviewed some of the research to try to get some answers to whether or not it was even worth kind of going down this road. So looking through the research, I mean, there's many studies that support the efficacy of sputum induction, but I did want to point out a couple of the larger ones. So this first study, this is out of the Montreal Chest Clinic. This was published in 2001, and they had 500 participants in this study. They collected over 1,100 induced samples. They did about 15 minutes of sputum induction, although it could go much longer, as I'll get to later. And they used 3% hypertonic saline in this particular protocol, and they used it to induce multiple sputum samples. And then what they basically did is just track the yield of the positive results. And they did exclude those that had recent asthma exacerbations. They also excluded anybody who was already on TB treatment for obvious reasons. So the results that they had, which this table kind of shows some of them, is that they had at least one adequate sputum produced in pretty much every patient, 99.8% anyway. And that the positive yields increased as more sputum samples were collected. Up to 4 samples were collected per patient. And as you can see here, you know, once you got up to 3 samples collected, the yield for AFB smear was 91%, 99% for PCR and culture. So the authors in this study did conclude that this was safe, well tolerated, inexpensive, and that you're able to get an adequate specimen in almost all patients. So they were really kind of promoting this as a standard of practice for the diagnosis of pulmonary TB when your patient can't produce a spontaneous sputum, or if you're getting smear negative samples. So that study, I kind of felt like showed, you know, some pretty good evidence that just the yield of sputum induction is pretty good. But how does that compare directly to spontaneous sputum sampling? I think that's kind of at the heart of this whole thing. And so we actually have a really nice study that was just published in 2022 out of Ukraine that tried to answer that question. And so this was a randomized control trial. They randomized 644 patients with suspected pulmonary TB into 2 groups with equal distribution of their baseline characteristics. They actually did a nice job. They were able to to do that with the presence of drug resistance, pulmonary area that was affected, and then the presence, number, and size of cavities. So I thought they did a nice job of kind of dividing those groups up. And then the intervention group, they did sputum induction with about 7% hypertonic saline. They did this for about 5 minutes most of the time. And then they had a control group that just coughed up their sample spontaneously. And both groups had smear, NAT, culture performed on one sample, and then the next day they collected another sample and they did AFB smear and culture on that one. And so what their findings were, which is some of what I'm showing here in this table, is that the control group, and this was the group that was not induced, they produced low quality samples almost 4 times more than the inhalation group. And most patients in the study were eventually diagnosed with TB, about 96% of them. But when they looked at those that were lab confirmed to have TB, in every testing method, the inhalation group had a higher positivity rate, as shown here in this table. So, and it wasn't by a percent or two, it was really by 12 to 14% across the board. So statistically significant in every category of testing that they did. So, their conclusions came down to, the patients who produced sputum samples spontaneously were about 3 times more likely to not have microbiological confirmation of disease than those patients that did have sputum induction. So, this has obvious implications for how quickly we diagnose with somebody with TB disease in clinical settings. But if you also kind of think about how that carries over to public health implications, such as how infectious we believe somebody to be, whether or not we do a contact investigation at all, when we remove people from isolation, those things are all going to be affected. So it seems like in all facets of TB care, when sputum results are being relied on for clinical or public health decision-making, sputum induction might be a helpful and important tool for us to use. So what about safety? Because that's always like the number one question anytime I bring this up, at least with our local health jurisdiction partners, is, what about the safety? And understandably so, right? So the primary concern really is bronchoconstriction during induction. And we can actually look at these 2 studies that I just kind of outlined here for some answers about safety. But one thing I do want to point out, there doesn't really seem to be a real standard way to do sputum induction. Many studies do some kind of pre-medication before induction, but not all of them. But when they do, they use some kind of short-acting bronchodilator like albuterol. And this is thought to prevent bronchoconstriction, obviously. Now, in the Ukraine study, they used no pre-medication at all. And they reported that they only had mild adverse effects among the 325 adults that were in their inhalation group. Now, they theorize that this could be because they used kind of a higher concentration hypertonic saline, and it shortened the duration that they had to do this. And so, they only, in many cases, only had to go about 5 minutes to get a sample from somebody. And they thought maybe it was because, they didn't have to stretch it out so long. Like you'll see in some studies, they'll use like a 3 or 5% saline. And a lot of times they're using 30 to 90 mils of solution. They're going 15, 20 minutes to do a sputum induction. And so sometimes just kind of that long process just leaves more time, I guess, for adverse effects. At least that's kind of their theory. And I have heard this reported from some other public health agencies that are out there doing this right now. But certainly that's debatable. I mean, in the Montreal Clinic study, the authors there also reported that they had no adverse effects, and they did 1,100 sputum inductions. They didn't mention whether they used pre-medication or not, but they certainly used a lower concentration saline, typically a longer period of time, and they still didn't have adverse effects in their study either. So just food for thought. And then what about younger children? There's a few studies out there around sputum induction in children, but But I like this one just because it was very focused on the safety of sputum induction in children. And so in this study, they had 270 children. They were aged 1 month to 13 years. This came out of South Africa. And these children all had suspected TB. This was done in an outpatient rural setting. They were all exposed to a household member that was recently diagnosed, or they had newly diagnosed HIV and respiratory symptoms that were concerning. So the only exclusions were those kids that had severe uncontrolled asthma, and they did do a pre-treatment in this particular study. They did 2 sputum inductions on most of the children. And I just kind of pulled out this one table here where they break down kind of their adverse effects. And you'll see really the most common one is nosebleed. and I think well, I know they talk about it in the paper, is that it was because they were using nasal pharyngeal suction basically with kids under 4 to get the sample.